I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Welcome to this episode of IDD Health Matters. We have a great guest today, Ley Linder. Welcome, Ley.
Thank you so much. I'm flattered to be here and excited to talk with you.
So Ley and I work together in a couple of ways. One of them, we co-author a series of articles related to behaviors and understanding behaviors. It's actually called Unlocking Behaviors in People with Intellectual and Developmental Disabilities. So that's kind of really how Ley and I got to know each other. Tell us what you do in this field, Ley.
I'm a board-certified behavior analyst. I also have a master's degree in gerontology. So I guess you could say that I'm a behavioral gerontologist. But I also own and operate a behavioral support provider company out of Columbia, South Carolina. We serve around 450 individuals across the state of South Carolina. And we work within an interdisciplinary team approach with physicians, psychiatrists, nurses, residential coordinators, direct support professionals. We work within a team to provide behavioral support services to people with various intellectual disabilities.
So what is behavior analysis?
It's a fantastic question. If you ask me in front of
you have 30 seconds to answer no.
If you ask me in front of BCBA colleagues, my answer would be different. The answer I'm going to give you is my honest one, is that behavior analysis and behavior analysts in this population have to have a continuum of knowledge that is functional in the sense of what does the individual need. We are not prescriptive in the sense that we need to follow a formulaic process of antecedent behavior consequence. We need to understand what medical professionals are seeing, what prescriptions they're writing, what are the nurses seeing, what are the direct support professionals seeing, how does behavior become a communicative tool for someone that's nonverbal with profound disabilities. We cannot be formulaic behavior analysts. We have to be holistic in some respects, and we have to work within interdisciplinary teams to bring in other specialties and be inclusive. I had a wonderful conversation with someone earlier in regards to the use of cognitive behavioral therapy for our individuals. We have to, as behavior analysts, bring in those other disciplines, or we're not going to get the outcomes we need.
And so what does it look like, say, to I don't know if this is the right way to say it, behaviorally analyze someone? What are you looking at? Let me back up. What might be something that you might be called to evaluate? What's a good example?
A great example is, and one that's very easy to illustrate, is someone that may have GERD or reflux. Okay. And we get a call and they say, Lee's spitting at us after dinner, and when we go to, when he leaves the table, there's a pool of saliva on the ground. We need you to come in and tell us why they're spitting and why there's a pool of saliva on the ground. And
so basically you're called because a person may have a challenging behavior or some dangerous behavior, and then to help figure out what's the cause.
Exactly.
Okay.
Exactly.
All right.
And in the example of the person that's spitting, it's not aggressive behavior if it's rooted in GERD. It's rooted in reflux. They are trying to expel excess saliva, or they may be regurgitating something into their oral
and maybe
cavity.
they can't tell you that they're, I'm having heartburn, or my chest hurts, after I eat. So the only way they can express it is through that particular behavior.
Or banging on their chest, or some form of self-abuse that only occurs in these certain contexts. So our job is to go in and analyze temporal dynamics. Is there certain times of day? Is there certain environments? And try to identify the cause of the behavior. And if that's medical in this scenario, then we say, hey, we need to get this person in front of a medical professional, not a full functional behavioral analysis.
So one of the things that I talk about a lot when I do talks is that connection between behavior and underlying medical conditions, because we see that so often, just like what you said with GERD. We see it with dental conditions. A person might be chewing on things or biting things, and it's because their teeth are hurting, or not biting things, or not eating because their teeth are hurting, or hitting out at others because they're in some sort of pain. But there are other things that cause behaviors besides underlying medical conditions.
Absolutely. Us, people, a lot of the places that we work are in group homes. If I lived with 3 other individuals with staff coming in every day, that can cause behavioral issues.
Especially, none of us, well, let me rephrase that. We all have preferences in the type of environment we'd like to be in, the type of people we'd like to be around, and we do things to avoid certain situations that we don't want to do. But sometimes in people with intellectual and developmental disabilities are in a particular setting, and they don't have that degree of choice. So you're saying that environment might cause a behavior?
A little bit.
Okay.
A little bit. Choice is a huge area of topic and discussion within this field, but that is an area that most people don't get a choice in, is where they are, who they are living with and where they are living, particularly in the climate now where aging issues are happening all across the demographics in regards to people with intellectual disabilities. Not just them aging, but their parents are aging, which are creating crisis situations of placement. Yes. Well, when people are going where there's a bed available, that is eliminating their choice of where they're going to live.
Yeah, if you have an urgent situation like you've been, person's been living at home with their parent or a sibling, and that person becomes ill and can no longer provide the support that person needs, and all of a sudden you've got to find a place for this person to live. There's not often very much opportunity for choice.
Absolutely.
There. Right?
And I would say second only to undiagnosed, untreated medical conditions, that is the largest antecedent or setting event to behavioral issues that we see are environmental components related to people that are moving into residential group home settings that don't have a choice of where they're living.
And when we say antecedent, we mean the thing that happens right before
minutes,
the behavior starts.
Seconds or minutes, and setting event would be something that's happening hours or days prior to.
So it sounds like what you're saying, that adverse behavior is rarely just what somebody with a disability does. Oh, that's just what they do. Let's just treat that behavior with some medication and see if we can settle it down.
I laugh because I was having a conversation just yesterday with the state director of a provider agency where we were both agreeing that when we walk into a home and the staff may say to us, well, that's just what they do, that's who we go to first. Yeah. because that is not just what they do.
Yep.
We cannot become, what's the right word, used to or conditioned to the idea that that's just who they are. No. There's always an explanation. It may be hard to find. It may be buried in the depths of a file somewhere, so to speak. But the idea is that it's just what they do, and that's why they are self-abusing, or that's why they engage in some type of aberrant behavior, if you will, that's not true. I don't believe that.
That is, frankly, one of the biggest lessons that I had to learn as a clinician coming into this field, kind of falling into this field many years ago, beginning working at an ICF, intermediate care facility, being responsible for the healthcare needs of a lot of people with very significant levels of intellectual disabilities and complex medical conditions, is understanding how behaviors is so often a presenting sign of maybe a medical condition, maybe an environmental condition, some social condition, a medication side effect. There's so many different things that can cause behaviors, and it is not just what they do. And again, I can humbly say I had to learn that the hard way a few times after thinking that might be the case, and then finally figuring out, oh my gosh, this person was suffering again dental issues. That's a big problem, or chronic constipation problems, which causes discomfort, or gastroesophageal reflux, which can cause all kinds of things, or they don't like a noisy environment, but they're being asked to sit in a room with 10 people who also might have other behaviors, and the TV's on loud, and so on and so forth. And sometimes it may be as simple as just providing an environment for that person that they're more comfortable in, that can change these, quote, just what they do behaviors.
Absolutely. And I think that to the point of the setting dynamic in regards to being in a room with 10 other people, whether that's a work dynamic or residential facilities, understanding what that person needs in order to be comfortable in their own home is incredibly important. It shouldn't be dictated based on our arbitrary rules of what's easiest for us to provide the service. It should be done with what do they need. I was talking to a gentleman I work with yesterday who he went into the home. The gentleman was having a lot of problems. We went into his bedroom, and he doesn't have what we were calling his bubble. He didn't have an opportunity that when he was upset or needed time alone or anything like that, that you or I would do with relative ease.
On our own.
On our own.
I'm going to go sit
He
in the
didn't
living
have
room
any
for
of
a while.
that.
Yeah.
For him to get away and be alone and to, as I say, recharge or whatever it may be, he did not have that option. And we walked away thinking this is a fundamental component of what the behavioral issues are, is because when he would have behavioral issues, what would he get? Time alone.
Yeah, and he learned. So that's the learn component. Sometimes is people do learn to have difficult behaviors because they get rewarded in some way.
Absolutely,
for it.
and it gets into more of a behavioral analysis discussion in regard to the function of behaviors. But absolutely, they're learning, and all behavior is learned. And I think that to your point a minute ago about it's not just what people do; some of it's what they've learned to do. What we've taught them.
That's right.
We've taught them that it is easier to get attention by banging on a wall, which I will not do, than to say, Craig, can I have a minute of your time? Well, if I bang on the wall, you're more inclined to come faster. It's a more efficient behavior to bang on the wall than to ask.
Yeah, and understanding that no matter what you do in this field is so incredibly important to providing good supports to people. Speaking of doing something in the field, how do you, is this a rewarding field to work in, would you say?
I have the best job in the world,
Wow.
hands down. I wake up every morning and I cannot wait to go to work. In a moment of disclosure myself, I'm a huge proponent of therapy for our individuals, but I also myself go to therapy, and it's one thing that I talk very routinely about is the dynamic that I don't understand why I'm so lucky, because I have the best job in the world. I love what I do. I love being able to come out here and interact with folks like yourself who are like-minded. I love being around people that are successful and doing phenomenal things, but there's an inherent intrinsic value into going to work every day that cannot be replaced working in this field.
Because what you do makes a real difference
Every day.
in people's lives.
Every day.
Yeah.
And some days are tough.
That's for sure.
That's for sure. But I know for a fact that I could sit down and have dinner with yourself, anyone from your team, anyone from my team, and we would connect immediately over the clinical dynamics, the difficult days, but there's a lot of joy that comes from making an impact day to day. And I know that is at the risk of sounding corny, but I really do have the best job in the world.
Well, I can relate to that. Again, not without its challenges from time to time.
It would be fun if it wasn't hard.
Yeah, that's right, because there's a lot of satisfaction that comes from figuring out something that's really challenging and difficult, and moving it forward and making it better, or resolving a particular issue, especially when you know that you might be relieving unnecessary suffering.
Absolutely.
For another human being,
which is at the apex of what we do, is relieving that suffering and improving quality of life. But to your point about the ongoing education, I was speaking with a new colleague that came on to work with us recently, and she's a perfectionist. And my comment to her was, this isn't a field of perfection, because if we were perfect at it, we'd never learn, and the fun would go away, because everything is different every time. There's similarities, but that's the other dynamic that I'm so fortunate about, is I never quit learning in this field. There's just too much unknown to not be able to continue to learn every day. It's fascinating.
It's a great perspective to have. I like to say that I never want to be an expert. I always want to be becoming an expert, because that means I'm always learning. I'm always moving in that direction. Absolutely. And I always have my mind open to learning something new.
Absolutely.
Yeah, and we certainly do see a lot of interesting and new things in
we've
this
discussed
field,
some of them,
which can be exciting as well. I'm Dr. Craig Escude, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support. So Lee, one of the things I like to do on the show is to ask guests to give us 3 things in 3 minutes that you would say can help improve health, wellness, health equity for people with intellectual and developmental disabilities. So, go.
3 things in 3 minutes.
Yeah.
Number one, hands down, I mentioned getting out of bed and wanting to go to work. Fighting diagnostic overshadowing, number one. I love that fight. That is my reason. I love fighting diagnostic overshadowing. If I even get a sliver, a hint of it, I'm like, I'm going to the appointment. I'm going, and I'm ready to fight.
All right, so I'm gonna give you your 3 minutes, but I need to make sure everybody understands what that term is. We've talked about it before, but diagnostic overshadowing is where we attribute, in this case, a person's behavior or a symptom of something to their overall diagnosis rather than looking for some underlying treatable cause, meaning, oh, this person does this behavior just because they have IDD or it's due to their intellectual disability. That's having that intellectual disability diagnosis overshadowing what actually might be causing that particular behavior. So that's number one, and I completely agree with that.
Big number one. Number two, and this is more of a personal one. You mentioned, or you asked earlier, like what we do as behavior analysts, and what exactly does that mean? For me, and from the framework in which I work, and my colleagues and folks that I work alongside, is the biopsychosocial model. I'm a huge proponent of that, in that it incorporates the biological and medical aspects of a person, the social components of a person, which I believe should go into, trauma-based care for our individuals, cognitive behavioral therapy, environmental dynamics with changes in, setting and living environments, grief, but also the psychological. And so many of our folks take psychotropic medications. Okay. We really have to be able to understand how those 3 main domains interact to incorporate the totality of a person, but also how we evaluate their, quote, problem behaviors within that kind of interaction would be my second. And my third, we have to be willing to touch people more. The power of touch in this population cannot be overstated. So many times I go into places and nobody wants to put a hand on someone's shoulder or hug somebody because there's this perception that they're wrong, they're infirm, they're disabled. I would say that one of the number one things that makes our outcomes better and more long-standing is the fact that when we go in and work with people, we touch people, and we hug people, we shake hands, we fist bump. I love with our folks that are more profoundly disabled, or the ones that I find have less tactile interaction, hand massages, stuff like that go a long way into providing a level of being able to connect with a person that may not be able to do it through words. And the power of touch is something we can't underestimate working with this population and finding powerful outcomes.
That is one of my favorite 3 in 3 things that I've heard so far. Is the touch thing right there, and I think that's invaluable. We are a society that thrives on connection, and a lot of that connection is through touch. I love that. Lee, it's been great talking with you. I love the insight that you have into this field. I love the passion that you have for this field. I love that we're working on a project together, and that is the Unlocking Behaviors series. It's in the Helen Journal of Human Exceptionality, so you can find that online and look for our articles. Look up Unlocking Behaviors, and you'll find that. So Lee, great talking with you. Thanks.
A pleasure. Flattered
Thanks
to
for
be
being here, and thanks for the work that you do in this field.
Thank you so much.
All right, I think we should touch.
Yes, we should.
All right.
Well done.
The IDD Health Matters podcast is a production of Intellectability. Learn more about our health risk reduction tools and training for supporters of people with IDD by visiting replacingrisk.com.